trauma, the electroencephalographer has no role. And that is so important that goes into the classical chant, and that came out of those special times after World War II, after the Korean War, when the war was the trauma in all its variations, but such a common thing. And now when you see traumatic cases coming, first of all, a good number of them have a bloody mess on the head, and that's not good for EEG. That alone is not good. There may be a bash knocked in skull, and even then you wouldn't put electrodes on it. As a matter of fact, it's so important to have to adopt the neurological, neurosurgical viewpoint. And what is it? To look at the patient, and first I look, does he blow a pupil? Does he blow both pupils? Does he develop extensor spasms? And that is so important. Suppose that there is, it may be just, first of all, one ordinary contusion, maybe just especially in frontal and temporal lobe, and you would see a good delta focus, but we don't lose time, not at all, because that swelling, that comes from that secondary cerebral edema around that. And that secondary cerebral edema, that can go down and can give you in the brainstem, a herniation, a transdentorian herniation, and there is pressure then on both the lomotor nerves, and the pupil starts to blows up on the side or on both sides. The both sides is the primary cerebral edema. Oh, that's I saw a man coming, somebody has hit a champagne bottle over his head, and with all the terrible force, the bone didn't break, but the pressure wave can go down and disturb the brain cell. He died in less than 5 hours. They rushed him to me to the EEG, and I was flattening EEG and was glad when he was out of the lab. He died right afterwards. So when they die, then they usually die in the first 6 hours. But it is so important that you get a neurologist, neurosurgeon, and then you can see what can be done operatively quickly. And it's so beautiful what MRI and CT scan can show you in this. This is absolutely fantastic. Before I just the case of the daughter of Vanessa Redgrave, what was her name? She was a beautiful woman, 45 years in the springtime. She was skiing in the Canadian mountains, and had a fall, and she was, after the fall, she was talking and so on, and after 3 hours she stopped talking, and then she gradually, the consciousness went down. Now, she came in a Canadian provincial hospital, and they were so great. Unfortunately, we don't have any neither MRI nor scanning mechanism. So we left them there, and she was already in coma when she arrived in Montreal, and they sent them further to the Columbia, New York, where she died. That is an epidural hematoma, which takes a few hours to develop, and this is the first hour. The patient is totally lucid. It's fantastic to see that. And then then you have to be as fast as possible. What can you do? Let's put it, when I was a young neurologist, there was even no brain scan, no CT scan, no nothing else. So what we did was immediately call the neurosurgeon. Then for the time, just an X-ray is the bone, is a fracture line. When there's a fracture line, it ruptures the epidural artery there, and that makes an epidural bleed. And this will take hours to develop, and it's so easy to do something in this moment that the blood goes out, and so that is such an exciting situation. And I was sure that the Canadian provincial hospital wouldn't do anything, because every decent general surgeon can make a protocol. There's nothing, there's no excuse in this case that this has happened. So unfortunately, I disagree with the role of the EEG in the acute trauma, and so he just impedes the whole evaluation of the patient.
Well, as soon as I saw Dr. Niedermeyer in the audience, I knew that this was going to be an interesting panel discussion. First, there's no way any electroencephalographer in this country or globally cannot feel humbled and grateful in your presence and for your contributions. I certainly and I'm so glad you did. One of the definitions of a compliment is to be criticized by those in positions of honor. And I consider myself complimented, Dr. Niedermeyer, that you took this much energy. I think there are two, and I want to be fair to my panel, so I'll try not to spend too much time. However, I think there are two issues that can be distilled down, and they are important. And they've been concerns for as long as we've been talking about introducing EEG as an acute electrophysiologic test. One is whether the EEG delays other important modes of treatment. And I think, if I understood one of your criticisms correctly, Dr. Niedermeyer, one fear is that waiting for the EEG to be put on, waiting for the results, they actually run the risk of delaying critical interventions such as a burl and an epidural hematoma, such as the unfortunate Nicole Richardson had, or interfering with the observations of critical clinical signs, such as enlargement of the pupil or Kernighan's notch phenomenon. That is certainly a worry. My response would be, it should worry us about any diagnostic intervention. I cannot tell you the number of times I was called to have been called to the emergency room for acute brain injury patients, and they're in the CT scan in the queue, waiting for that CT scan to be done before even the neurological exam was done. They came in with a history of head injury, and they're in the queue to the CT scan. I think we have to be very careful in deciding on a priority basis how to attend to our patients, whether it's acute brain injury, trauma, metabolic encephalopathy. And if we do that, I think we can get through what appears to be an objection with good clinical judgment. Nobody, and I certainly would never object that a patient who has a depressed skull fracture, lower level of consciousness, a suspected subdural hematoma or epidural hematoma, the imaging of choice, the procedure of choice, neurological examination, and imaging study. Don't delay things by trying to set up an EEG. My point, however, is, as I indicated in my first slide, that even when you find that epidural hematoma, or even when you find that subdural hematoma, and take care of it, if that patient, in spite of the intervention, has an unexpected decline in level of consciousness, we have to find the reason. And if it's not caused by that structural injury that we've already treated, we know that disease is not just structural, it's physiologic, it's pathophysiologic. Our clinical examination is actually an attempt to elicit pathophysiology at the bedside. But when a patient is sedated because of rib fractures or a ruptured spleen, or has a GCS of 9 because of a contusion, our clinical examination is necessarily limited. By the time the patient closes the pupil, that temporal lobe is already under the tentorial notch, and we have to catch up. Far better to know what's going on ahead of time and to be proactive. And we have the good fortune to have the technology, the expertise, and the capability now to proactively bring to brain electrophysiology what Einthoven did in the 1920s by bringing electrocardiography to the heart. We know what's going on inside the heart. We know if there's an arrhythmia, and we can treat it proactively. There's irrefutable evidence, as uncomfortable as it may make us, that non-convulsive or subtle seizures occur in every type of brain injury we can define. Now the question becomes, what do we do about it without interfering with other necessary interventions? I think that is the challenge, and hopefully we will be even half as successful in answering the challenges of our generation now that you've been in answering the challenges of yours and instructing us accordingly. So thank you very much.
I pose this question to you as coming from a small lab in a relatively small hospital. We've seen the numbers on non-convulsive status, how fast we've got to we've got to get down there and check them out. The biggest problem for us in small areas is how do we justify having this equipment? Has anybody done a study of cost analysis on how fast we can treat these people, if we can get them out of our intensive care units, or if they're laying around for 5 days before somebody actually says, gee, maybe they're in non-convulsive status. How fast we can clear this up and move them along in our systems. I think that's the only way that our administrators are going to see the value of what we do, what we can put in dollars and cents. That's unfortunate, but has anybody done anything?
Should I go for a twofer, or a two-part answer, if I may? When we look back at the transitional behaviors of medicine, where things shifted on a large scale, whether it was the introduction of cardiac angiography, or TPA, or balloon angioplasty for cardiac disease, three variables converged. One was the demonstration of clinical efficacy and benefit because of that intervention. The second, and this goes to your point, was that in one way or another it was cost beneficial, not the same as cost effective, cost beneficial. It extended people's lives and quality of lives if you did it, even if it was expensive. Okay? Nobody's done a cost analysis on MRI scans as far as I know, but they become ubiquitous, and even administrators check off right on the check. That's part one. Part two is, if we just look at the STAT EEG study that we presented to Neurocritical Care Society a few years ago, and I had the table up here, we identified, and this has been replicated, 11 to 12% incidence of non-epileptic seizures in patients in emergency rooms who were convulsing. Other reports have been 18%. Those patients receive abundant amounts of anti-seizure medications, Every year, there are at least 2 or 3 reports of fatalities due to over-sedation. These patients are intubated, they're brought into the ICU, and they leave to come back to another emergency room another time. Simply identifying the non-epileptic seizures in seizure patients in emergency rooms, I think would be a phenomenal cost savings. There is emerging data, but it's not compelling yet, but there's emerging data from UCLA that identifying non-convulsive seizures in intensive care unit patients reduces the need for additional interventions and allow those patients to leave the ICU earlier. So I would say 2 things. First, change occurs when you get clinical benefit. Second, cost benefit. And the third, which is something that we always talk about except at conventions, is liability. The third leg of large-scale change, at least in medicine, is when the stakeholders become worried that their liability is greater when they don't do something than when they do. And we're close to the point, I believe, where hospital administrators and perhaps physicians are becoming more concerned about missing non-convulsive status epilepticus than expending the resources to find it. And it'll be a very interesting opportunity to see where this goes over the next few years.
Expanding on kind of what he was saying on the cost benefit, you had the list of other healthcare providers who would start the STAT EEG. We recently had an incident in our hospital where our neurologist ordered a STAT EEG at 9 a.m. and the unit clerk and the patient's nurse decided they didn't know how to order a STAT EEG. And 9 hours later, paged the EEG tech and said, gee, can we still get it? And the patient sat in non-convulsive status epilepticus for 9 hours. And so the delay was not that they couldn't get one, they just decided not to order it. So in an economic time when hospitals have been laying personnel off and hiring freezes, and we've got personnel that not me works in our hospital, and you've got departments that are saying, I don't have enough personnel to do what I need to do now. How do we convince them to get a respiratory therapist to do a STAT EEG or a PA or overworked personnel that can't get what they need to do done to do a STAT EEG when they wouldn't even put the order in for a legitimate thing during working hours when I had enough techs there to do the procedure 8 times over? We can do it now. And they didn't even put the order in. And they fried the patient's brain. She's now brain damaged. So how do we do this in an economic time when they're cutting things to the bone and we're trying to save the brain?
Very good questions. All these questions are very good. I have to say 2 things. First, having lived in this certain peculiar community of acute brain injury and electrophysiology for a number of years, and having a little bit of tread wear on my tires, I can say that the level of discourse today is quite different about this problem than it was years ago. The question that we're being asked very appropriately is, how can we get this done? A few years ago was, why even bother? So I think we're making progress. I believe that, especially because STAT EEG programs are expensive, they burn out technologists, and they do so with the best technologists. It's hugely burdensome. But especially because of that, we need solutions that are much smarter and much less expensive. It's pennies to have that EEG read by the neurologist at his home rather than have the neurologist or his or her come into the emergency room. It's pennies to have somebody already at the bedside, whether it's a nurse practitioner or a respiratory therapist, set up that EEG on an inexpensive template, then calling in a tech. That's cost savings to the hospital. It's further cost savings to treat the non-convulsive status epilepticus early so the patient survives and gets discharged. That's cost savings. Brain is time. Early treatment means early recovery. What you described, and it's not unique to your institution, I believe is not an individual's or two individuals' fault. It's a call to us to make sure we have our protocols in place. What's the protocol for that STAT EEG? So when it's ordered, that word clerk simply punches up on the computer STAT EEG and it protocol's right there. A lot of hospitals are going to computer physician orders, so it's documented when the order is put in. So I think a well-constructed protocol that goes to the appropriate hospital committees, that then is shared with all the stakeholder entities, perhaps reviewed at a conference and signed off by the appropriate committees, is a good way to get everybody on board. And I think if you add up the cost analysis to what's happening now to what would happen in a technologically based STAT EEG program that uses on-site personnel, I think you'll find that the cost savings are going to be quite impressive and speak for themselves.
We have time for maybe one more question. If anybody has any questions?
Dr. Jordan, thank you. I appreciate your meaningful participation on that. I am so happy about that. It's ordered, it's got to be done, whether it be something in the hospital setting up or not. The theory is, and I agree with a lot of things like your echocardiograms and your CAT scans, and they're STAT readings, they are perfect. What we do at our facility is that the test is ordered by the physician who says, hey, you know what, call the on-call test. Get them in and out. This needs to be done. It's a direct doctor test. Call. If the physician can't be there, such as an intern calls a neurological consult, and a neurologist says, well, why don't we just get an EEG? The technician wants to test the list to a again, you can see it on black. And I think that is where we need to go. We need interpretation. It's not that I've worked with facilities where, third-year residents will say, well, what if the EEG show? I go, no, call the doctor. I will let him know what I do. He will make the call. A third-year resident who is a non-neurological resident doesn't know what I'm telling them. So we need interpretation, whether it be online or any other methodology that they want to utilize. Absolutely, I am totally for it. Having anybody set it up in the hospital, if your hospital wants to go that way and pay you $2, you don't need that way. I can't change that. She's right. If the economic changes, having it easy for 9 hours before it's actually people having to participate. Doctor, actually, for
to the whole. Today.
In some facilities, the doctor's the only one that has to write the order. I know. A court can't.
But what I'm saying is if you have a fault with a model, that model is a great thing, but even if the physician writes the STAT order, if you've got a nurse who says, I don't have time to do a STAT EEG, it can still fall from
It may not be my position, but I sense a conference is at risk of turning into a dialogue. Amber, are we, and I don't want to monopolize the panel if they have any.
We have a few more minutes, but.
Oh, yeah. Definitely don't.
My question is, as a profession, we say we're the ones that are going to be doing the testing. We have the credentialing. We're the people that are going to do it. So why are we asking the respiratory therapists and begging them not to do our EEGs? You know, why are we now wanting them to do our EEGs? I don't understand.
I guess that means I can't give this over to my other panelists. Two answers, if I may. And this is, years of working with the best technologists and a great deal of respect for EEG technologists. And I'm going to couch my answer this way. I have so much respect and regard for EEG technologists over the years that I want to see this profession tap the best in every one of you. And I think you're better than manual laborers, if I can be blunt. I think you're better than being asked primarily to stick wires on the scalp. We have gone from those remarkable machines we saw in the lobby with individual inkwells and amplifiers and pens and paper. That's what happened in 1959 when a bunch of technologists were the only people who could figure out how to run the damn things got together and say, we have so much expertise that we're going to share this common body of knowledge. Now we're in the digital age. There's no inkwell. There's no paper. There are not multiple amplifiers. But we're still slapping wires on the scalp as perhaps the remnant of the decades ago, 5 decades ago, when this organization was formed. That's the only activity that any of you is currently doing that has not modernized. That's telling us something. Once we modernize the setup, you're liberated to start cognitively being the superior neurodiagnostic technologists you are. Help us interpret this volume of studies that we need from an emergency room, from the intensive care unit, from all these studies that the neurologists either don't read too late, don't want to read. Let's figure out how we can become cognitive partners in saving our patients' brains. I don't want to simply see so much talent relegated to a 3 a.m. call to put glue on a wire on a scalp. I think we can all do better, and I'd like to see my profession work with your profession to help you all do better.
I think that's not really the route to go. I think applying the electrodes is going to give you, it's an important step. And if it's not applied right, your EEG is not going to be right. It's going to be filled with heart attack. If you're not that's a very important step of your EEG recording.
I apologize.
It's not manual labor. It's the number one step. If you don't apply them right, and a seasoned EEG technologist can put them on a little bit faster than I think your
making now.
No.
But to take that away, I think you're doing something harmful to the EEG recording.
And this is right. This is a very important question. My topic today is STAT EEG. It's not long-term monitoring, and it's not the Gibbons model of 164 electrodes to look for source dipole localization. There are 3 questions to answer in a STAT EEG, and we've dealt with only one. Is that patient's brain seizing? If we can answer that question on an emergency basis, we're done for the night. We're just done for the night. Come in the next morning, and we'll look into it more. We'll put on 21 electrodes, measured. We'll put on 36, 64, whatever we need to do. But with a STAT EEG, the question is, how do we get there fast? How do we set up the electrodes sufficiently accurately to answer the question well? And we all have had an ambivalent relationship with templates. I was trained at Columbia, and if you even, said the keyword, you were sent it to the corner. However, given our current reality, and if you actually look at some of the way these templates work, and I want to make sure I don't blur the line of conflict of interest, they're accurate in conformity with the 1020 system, they're consistent, and they answer the question whether that patient's having seizures. We're not really worried about a spike focus on a STAT EEG. We're not interested in whether there is a focal area of intermittent slowing. It's a triage procedure. And the next morning, we get involved with a lot of detail in writing it down. So there's no question, and I don't want to even invite the argument because I'm on your side, that precise application of electrodes measured by the 1010, 1020, or other established system by a well-trained technician, a neurodiagnostic technologist, has an important role. But what are we going to do with that patient at 3 a.m. on Saturday who has an unexpected decline in level of consciousness? And my point is, that person on site can do it, can be trained to do it.